Hey, this is Andrea Kane here with you for HIT 330 Healthcare Delivery Systems. And this is for week 14. Happy Thanksgiving week. And we are on chapter 16 in your book, Fraud and Abuse Compliance. We are touching on some pieces of financing healthcare as well as quality in healthcare. Next week, we'll be really diving into quality in healthcare, but this kind of finishes up the financing healthcare from week 13, which is last week, and then kind of introduces us, sliding us into quality and healthcare for this week and next week. If you look at your syllabus, we are on unit objectives, and those unit objectives obviously reflect that it's from last week and next week, with 9.5.1 through 9.5.11 and 9.9.1 through 9.9.6. If you are following along in your book, you will want to be on good old page 499, which is where we start with our learning objectives. The book says we need to differentiate among fraud, abuse, and waste, identify elements of a compliance program, examine the legal and regulatory requirements that are related to managing a compliance program, look at the purpose of audits, look at benefits of a code and compliance plan, explore the need for involvement of HIM professionals in clinical documentation integrity, identify clinical documentation integrity metrics, and differentiate between organizations involved in the federal regs and initiatives around fraud and abuse compliance. And there are several, quite a few. And I've actually met some of them in my travels between 5 states. And it has been very interesting. And they are, for the most part, very good people who truly want what is best and what is right. So the conversations I have had have been really good. I will say that. All right, so flipping over to page 500. Unfortunately, anytime you get into anything involving money, and all of us know this from life, there are needs for laws to combat fraud and abuse, because no matter how good everyone's intentions are, there are always a few people out there that unfortunately choose to commit fraud or abuse. So let's talk about that. You will see, I don't know if they do it here in the book, but the history behind fraud with the federal government has to do with the American Civil War, or the war between the states, depending on where you grew up and what your perspective is. And I'm not meant to get into that political landmine today. But anyway, during the Civil War, there were some gun manufacturers who sent defective rifles and cannons and those types of things. They sold them to the federal government for the Union officers and soldiers, knowing that those rifles and cannons would not perform well, would not perform at all, or might actually explode and harm the people who were using them. And out of that came legislation that basically said you have to, if you are providing goods or services or items for the federal government, you have to be able to prove they have to be of good quality. And if they're not of good quality, you can be prosecuted for fraud. And so that's the background of where it came from. In your book, it says fraud is when someone intentionally executes or attempts to execute a scheme to obtain money or property of any healthcare benefit program. That is healthcare fraud. Notice in that definition on page 500, that is intentionally. Intentionally. Fraud is always intentional. Abuse is always unintentional. So when you're going through here and you're thinking fraud or abuse, fraud is always deliberate. It's always intentional. Abuse, it can be error, waste, or bending the rules. It's not intentional. Someone didn't set out to commit fraud. Abuse is, though, damage was done, even if it wasn't intentional. So make sure that you know those differences. And that's covered pages 500 to 501. So make sure you read through all those. You need to know all of those terms that are in that seafoam green color, all of them. Some healthcare professionals exploit the healthcare system. And we have seen this, and you will see this as you go through your studies, because we actually go in and we look at cases of where health professionals have exploited the healthcare system. That is fraud. Some healthcare organizations have poor billing policies and procedures. While that could be fraud, if you can prove intentionality, most often it's abuse. It's not taking the time or effort to make sure you have good billing policies, procedures, and practices, and that sort of thing. When you have improperly trained staff, that can result in unintentional billing errors, which is also considered abuse. And the whole point behind these laws for fraud and abuse is to ensure appropriate reimbursement. And as we get in and we study fraud and abuse in other classes that you have, you will be horrified by the billions of dollars that have been paid out in these fraudulent and abusive claims, and then the government has gone back and tried to recoup as much money as they can. So again, fraud, this is intentional. This is deliberately trying to get money when there's something false involved. Abuse, again, that is, you didn't necessarily set out to defraud the government. There wasn't an intention there, but the end result of what you did was wrong. And that caused receipt of money inappropriately, and that's abuse. Okay. Unbundling. All right, so it's going to take us through these unbundling, upcoding, and non-covered services. And those are also, are those listed here? Yeah, those are on pages 500 to 501. And I'm going to have you go through your book and take a look at those as to what they are. And then, of course, you've got the slides here that you can look at as well. And yeah, and that covers overpayment as well. Figure 16.1 in your book is a helpful visual, I think, of going through all of these. And talks about non-covered services that people might try and bill for as well. And then waste. Waste would be that a person only needs 4 visits to take care of, perhaps they're getting physical therapy and they only need 4 visits based on their progress to be at the point where they can be discharged from physical therapy, but instead someone may document inappropriately, or a doctor may order 4 more extra sessions of physical therapy that the patient doesn't really need. And that would be an example of waste. And that's also a type of abuse. And waste can also be fraud, so be careful there. If you intentionally order, as a provider, if you intentionally order inappropriate or overutilization of services, and it's to gain money from Medicare or Medicaid, that is fraud. That's not abuse, because you're intentionally doing it. Mistakes, that's definitely part of abuse. And then you get to compliance. Compliance is the process of establishing an organizational culture that promotes prevention, detection, and resolution of instances of conduct, conforms to federal, state, or private payer healthcare program requirements, follows healthcare organizations' ethical and business policies, and actively prevents fraud and abuse. I have worked in several organizations that had compliance programs, and they have done it to varying degrees. I want to point out here, it's establishing an organizational culture that is very challenging to do. That comes from the top down. That means that everybody is living this out every day, every patient, every time. And I will tell you that there are very few organizations that truly do that, unfortunately. All right, so federal regulations and initiatives. You have the Office of the Inspector General. They are the office that works to combat fraud, waste, and abuse, and you will definitely be looking at their website and some of their information over time while you're in classes. You don't need to know that today. What you need to know today is that they exist and that they are combating fraud, waste, and abuse, and trying to improve the efficiency of HHS programs. That's what you need to know. False Claims Act, this is what I was referring to as to how this happened. A key component of the False Claims Act, and this is on page 504, is qui tam. That's the whistleblower provisions, meaning that if you are working for an organization that is knowingly submitting fraudulent claims to the U.S. government, you can be a whistleblower. You may be fired by the company, and that reputation may follow you into other jobs, but the government, if they collect money, they will give it back to those who were part of the qui tam. And again, this just goes through it. And it gives the provisions of the Whistleblower Protection Act. You need to know the False Claims Act. You need to know the Whistleblower Protection Act. Not so much the details, so much as just that they exist and really what was the basis for them. You need to know the same thing about anti-kickback statute and the Stark Law. What are those? How are they similar? How are they different? And I'm going to refer you to your book for that. Balanced Budget Act of 1997 and the Exclusions Program, how this created the database, and how every employee for a healthcare organization, including healthcare providers, have to be checked against this database on a regular basis. And if they're excluded, they cannot be anywhere a part of what the organization does in their revenue cycle. And they can't be a part of getting any kind of reimbursement if they are convicted of if they are excluded, if they've been convicted of healthcare fraud and they're part of the exclusion. And then HIPAA, you will hear so much about HIPAA. The first thing I want to point out about HIPAA, please burn this into your mind. HIPAA has one P. One P. One P. If I see two P's, I will mark that as a misspelling. Health Insurance Portability and Accountability Act. And this just talks about how this brought about this privacy and security standards, but they also went into fraud and abuse and talked about how there could be civil monetary penalties and convictions. And so how that came into being. Whoops, I went too fast, too far. Sorry. Okay, and this talks about how fraud and abuse can be prevented. This is now on top of page 506. So what this is when HHS determines the civil monetary penalties for an instance of fraud or abuse, the level of efforts that a healthcare provider or healthcare organization has put into fraud and abuse prevention is considered. These efforts can be grouped into the three categories: reasonable cause, reasonable diligence, and willful neglect. And so obviously if it can help lessen the civil monetary penalties if you were doing a good job with a good HIPAA program and something happened. Versus if you were not, if you were down on the willful neglect, you can pretty well be sure that the government's going to go after you with everything they've got, and they're going to go for the harshest penalties possible. There are lots of things that HHS, the Department of Justice, and the OIG have done together to proactively prevent waste, fraud, and abuse, look for it, and reduce healthcare costs and try and identify things before they get too far down the line. And so they're going to go through those with you. One is HEAT. the Healthcare Fraud Prevention and Enforcement Action Team. So that's one. They'll get into recovery audit contractors and how those work. And really quick, going back to HEAT, um, they are typically they have amazing statistics, and they use a lot of data mining activities where they have huge databases and they go through and they're looking for trends, and that's where then they start identifying where they're going to target. And unfortunately, fraud seems to be high in the biggest cities of the United States, and so they have focused there. Appalachia, or the Appalachian region, which I have lived in for 12 and a half years, that is pockets of that, and it's not usually the rural pockets so much as it can be some of the others. I was actually surprised to see that on here, but where I lived, we were very serious about not committing fraud and abuse, and the organization I worked for was very proud of, because they really did have an organizational culture of compliance. We lived it. So Recovery Audit Contractors is a government program. They identify improper payments. Originally, when RAC programs started, they got a pretty good cut of the money back. And so there was a lot of unhappiness between healthcare organizations and the government over recovery audit contractors. That has eased up a bit. The appeals process is still very complex and challenging, and keeping up with RAC requests. Typically, organizations have a RAC coordinator that handles all of these different appeal levels and whatnot. And so, and documentation requests. So this is on pages 506, 507, 508, talking about RAC. So you just need to be aware of all that and how that works. And again, we will cover RAC again many times over. There are 3 types of RAC audits. There's automated review, which is the most common one. There is a complex review where you have a coder that's working for a RAC organization who's reviewing it. They also have access to physicians, and you can sometimes arrange for a conversation between physician to physician, your organization's physician, their organization's physician, to go over it as part of the 5 levels in the redetermination reconsideration process. And then there's a semi-automated review where they start with the automated, and then they have someone in the RAC company look at it again. There's 5 appeal processes, and yes, you can get, I have been involved with it up through the ALJ point of view. I don't know that I've ever been beyond the ALJ level, but I know it is possible to get there. And QIOs, Quality Improvement Organizations. Yes, we actually have one here in Iowa, and we will be talking more about it. These organizations look at medical peer review of Medicare, Medicaid claims. They do audits. Sorry, I went too fast. And it goes through here about the regions and what they do, monitoring coding quality. They're also now getting into they look at diagnoses, procedures, opportunities for education, improvement, those types of things. Now we're going to get into MIPS and MACRA. We covered MACRA a little bit in the last chapter, chapter 15, and this goes a little bit further into MIPS. And it'll go through there. It should dovetail with a lot of what you read in chapter 15 with MACRA. And it is now known as Promoting Interoperability and part of the MACRA program. And this just goes through all that information. That was on page 509. And now we're into, I'm going to keep going. the compliance program. Compliance program, I feel like I should go back to MIPS for some strange reason. I guess, what do you need to know about MIPS? There are three parts of it: the value-based payment modifier, the PQRS physician reporting system, and promoting interoperability program. See, the thing with MIPS is it's essentially over with. It was replaced by MACRA. PQRS ended 2 to 3 years ago. So although it's nice to know that MIPS existed, and MIPS was originally known as Meaningful Use, and it was there, I don't know, it says here it came into being in 2010. And that's probably about right. They offered payment for EHR incentive, but it also determined your value-based payment modifier, and you had to report through PQRS. But all of this is gone. The last year that PQRS was reported, I believe, was 2018, 2018, 2017, something in there, 2017, 2018. And the last payments for the EHR incentive program or meaningful use, those have pretty much ended. I know some states are paying out through 2021, but most of that is all done and has been for a number of years, and MACRA's replaced it. So I guess you need to know it existed and how it worked, but I wouldn't spend a whole lot of time on it. Compliance program, this is page 511. This is a set of internal policies and procedures that a healthcare entity puts into place to comply with applicable state and federal laws. What makes an effective compliance program is that it enhances, or an effective compliance program enhances a healthcare organization's operations, improves quality of care, reduces overall cost, reduces liability with regard to fraud and abuse. If your program is effective. And how is it effective? It depends on the people, and it depends on the accountability. It also depends on how much compliance is in your organization's culture. So it's not just about having a program. You can have a very effective program, but if it isn't part of your culture, it isn't, if you don't have people that are really committed to it, it doesn't really matter. But parts of a compliance program that you need to have are policies, procedures, standards of conduct. You have to have a compliance officer and a compliance committee. Typically, there's a compliance committee that is made up of department directors and managers, but there's also one usually of the board. There's usually a subcommittee of the board of directors that looks at quality and compliance. You need to educate staff, establish communication levels, perform internal monitoring, and have penalties for non-compliance with standards. And when you do have problems identified, you have to take immediate corrective action to what those are. So those are the elements of an effective compliance program when you're talking about fraud and abuse prevention strategies. And so moving on, again, we go through a lot of what we went through before. You've got to review coding and billing. You need to look at your documentation. Educate, audit. And you need to not only do internal audits, but have external audits performed. You can have the best internal audits, but you've got to back it up with external audits as well, because they are unbiased people. They're coming in to take a look. They're not attached to the individuals who are doing the coding or billing or who have established the process. Sometimes when you're in the middle of things, it's impossible to be unbiased. And so it's really a good idea to always have external audits as well. And it talks about audits starting on the bottom of page 513, going into 514 and 515. Talks about types of audits. You can have coding audits, medical necessity audits, clinical validation audits, billing audits, all those improper payments audits. There's cert audits that happen been involved with all of those. And this just goes through the CERT process. And again, you don't really need to know this except to understand that it exists, that they select claims, they send medical record requests, they do a medical review, they calculate the improper payment rate, and they report it, and then you've got to deal with it. Why audit? Well, you want to reduce improper reimbursement, you want to improve accuracy of your claims, improve patient care, and show commitment to complying with laws and regulations. So audits are very important. And yet, you know what? When it comes down to it, when FTEs are reduced and when time is reduced and money is reduced, audits are one of the first things, unfortunately, many organizations give up. And it's the worst thing you can do, because audits are the one thing that will help you know if you've got something bad going on that you can fix right away. So just a little seed of advice for the future, that if you're in a situation, always try and fight to continue audits, because it may be one of the few things that saves you. How do you prepare for and conduct an audit? Well, you identify the objectives, you establish the audit method, you do statistical sampling, and that sort of thing. I have been through a number of compliance audits. In fact, when I worked in North Carolina, we had them every year. And yes, they were very anxiety inducing. But they were really great to show us areas that we needed to improve or that we hadn't really thought of. And they helped us build our own internal auditing program. And so it was all good. And when you think yes, audits are anxiety producing, but once you get beyond focusing on your own personal anxiety and you get beyond that, they're a great learning opportunity. So don't focus on the anxiety, focus on what you can take away, what you're going to learn from it, what you can share, how it will help you become so much better afterwards. And be grateful for those who are willing to share their knowledge and expertise who are doing the audit. They're not there to hurt you personally or professionally. They're there really, truly to help you learn and grow and improve. And if you could take it in that sense, it really becomes a positive occurrence and more of something that builds positive relationships. So the process is identifying areas of risk that need to be monitored, conducting an audit on those areas of risks, documenting your findings, analyzing the data, and correcting any identified problems. And these are all on, where are we at? I think we are on pages 516 and 517, somewhere in there. All good information. Again, make sure you know anything that's in seafoam green, and make sure you know the high points of each section. HIM professional plan audit activities. This just goes through all of those. This is on page 516. How you approach those, how you plan to handle those. Coding fraud and abuse. When you're doing the audit, you want to make sure the DRG is correct. Is there any unbundling? Are the codes that are assigned for the appropriate level of service? Are the codes changed? The non-covered services billed as a covered service? And is there any discrepancy between the codes provided by the physician and the hospital? I cannot tell you how many years I have preached that last one. And people thought I was crazy, but I kept telling them at some point the government's technology is going to be so good that they're going to be able to see what the physician billed and what the hospital billed. And if there's a huge discrepancy between the two, that's going to raise red flags. And especially when you're talking about CPT codes. And so that I'm glad to see that they have included this here. So you definitely need a coding compliance plan. Every provider or organization should have a coding compliance plan, and it should be very detailed, it should be very written, it should be very available, and it should be followed. You should be able to show you're doing what you said you would do. Benefits of having this compliance plan: you improve documentation, you make sure you have a high standard of coding, You reduce the number of denials, which helps with AR, keeping that flow going by reducing coding errors. And then you correct any coding related risks. Usually you find them very early on. You can fix them, you can do rebuilds, and you can get yourself to a place where you're not looking at 2 years worth of problems. You're only looking at 2 to 3 months worth of problems. Big difference there. So how can you combat fraud and abuse in coding? Training, 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 training. And this is unfortunately another thing that has been thrown to the wayside with budget cuts, is that they don't understand how important training is. If you're going to cut something, don't cut your people and don't cut your training. If you have to find other ways to become more efficient in your department, you do that. But you don't cut people and you don't cut training. And that's just my personal soapbox right there. Because training is how your coders are going to get their CEUs and how they're going to stay current and how they're going to make sure that they maintain the level of coding accuracy that needs to be maintained. Make sure you have comprehensive policies and procedures, that you've considered all these different areas. If a question comes up, do you have a policy and procedure that addresses that? Do you need a policy and procedure that addresses that? You've got to have a mechanism for doing that. And then how do you get your policies and procedures out? If you've got a new coding policy and procedure, how do you get it out? How do you make sure everybody knows what it means so it's not confusing? Examine the quality of coding through the use of audits. You've got to audit. You just got to. You've got to take the time, and you may have to pull a coder off coding to do audits, but you've got to do it. Ensure coding practices follow official coding guidelines. This is where you get back to Coding Clinic, and you've got to make sure that you've got that information that is coming into your coders, that they're being updated on a quarterly basis, and that they're understanding how this impacts what they're doing. And same with CPT. Support codes with health record documentation. Don't code it unless you've got the documentation. Doesn't matter if you think you can read between the lines. If you don't have the documentation, don't code it. E&M code assignment, again, documentation. You've got to have the documentation. If the documentation isn't there, then you either need to ask the provider to provide it, or you need to let it go, not code it, or leave it at the bottom level of the bottom code. You cannot code if you don't have the documentation. If the documentation is in conflict, you query and ask for that clarification. And you never ever mention reimbursement with documentation clarifications or coding queries, ever. Never mention reimbursement, because that's not really what it's about. What it's about is clarifying the documentation in the medical record for coding. Yes, coding does go into reimbursement, but it's for the record itself to be clear, and that then supports the coding to be clear and accurate. You need to educate physicians. I can't tell you how many times I've had conversations with physicians. Most of them don't understand coding or understand the documentation and links, or they're so busy trying to provide patient care and do the regular documentation, they don't always see how the impact can be. You have to find a way to reach out to providers, not just physicians, because you're talking nurse practitioners, PAs, as well as physicians, and talk to them about what's in it for them. How is this going to benefit them? How is it going to help them if a medical malpractice suit comes up? How is it going to help them with their own reimbursement? How is this going to make it easier in the future? You have to look at that. It's not just do it for the record. It's not just do it for me because I've asked. It's not just do it for the coding. It's how do they understand that by changing their documentation practices and improving those, it has such a massive effect downstream, not just for them, but for everyone around them. Use best practices to write a query to clarify documentation. You can never lead a physician. Your query has to be an open-ended question. It cannot be leading. It cannot mention reimbursement. And we will talk more about coding queries as we go forward, but that's basic. Monitor changes in regulations. You've got to be up on that. You've constantly got to be receiving information. You've got to go out and look for it. Every September, you need to be looking at the Federal Register. What's changing? How's it changing? How's it going to impact us? Who needs to know about this? And not just in your own department, but in the whole organization. Compare your facility metrics with national data. That's called benchmarking. So you've got to keep facility metrics. You've got to collect data on your own people, on your own activities, on your own coding. You need to use Pepper reports and all those other things. We'll go over those in other classes, but you've got to be able to benchmark. You've got to be able to see, is your facility about the same? Is it something really way off different? And why is it there that difference? Monitoring claims denials and coding changes, making sure that if you're getting a lot of denials, why are you getting all these denials? Is it being traced back to one coder who's making a mistake? Is it multiple coders? Is it something that you guys weren't aware of in terms of coding clinic guidelines or in terms of CPT definitions and whatnot? And then reporting possible fraud to the facility's compliance officer or attorney. You have to do that. If something comes up, you've got to reach out to that individual and say, hey, I have just discovered this. I need to investigate it further, but I've got to give you a heads up. This is initially potentially a concern. I'm going to investigate it. I'll be back to you on this date, this time with some kind of a report because I've got to expand what I'm looking at. But I'm concerned about XYZ because of ABC. You've got to do that. And this is coding query again. You want to use the documentation that's in the record and clarify what the concern is. Why is it not clear? And ask for it to become clear. And yes, it should always become a permanent part of the health record. Some people are still up in the trees over this and have not figured out it's got to become permanent part of the health record because it's got that clarification on there. It's a part of the medical record. Some people prefer to have the doctor go back and update or do an addendum to their report, and they can do that, but the query has to be kept. And the reason why you want to make it a part of your permanent medical health record is to prove if something fraud, abuse gets laid against you, you can show that code inquiry that's a permanent part of your medical record that you were not leading the physician. So you got to make sure of that, and that's a big reason why I advocate personally that it's a permanent part of the health record. Not everybody does, but I would say that if it's not a permanent part of the health record, that is not best practice. Computer-assisted coding, we'll go into this a lot more. We have now moved to page 519 in your book, in case you were wondering. And computer-assisted coding, that's extracting and translating dictated and transcribed free text data into ICD-10, CM, and CPT-4 codes for billing and coding purposes. Basically what it does is it uses natural language processing, and it goes through all of the documents in the record, and it comes up with the codes that it thinks it should have, and it presents those to the coder, and the coder has to go in and edit those. It's very much the same process of what happened with transcriptionists when transcriptionists moved from transcribing just based off the provider's voice to having it go through front end or back end speech recognition, and then they go through and they edit. Clinical documentation integrity, and this is on page 521 in your book. CDI, this is a process that you undertake to improve specificity of clinical documentation. It's typically done concurrently. Ideally, it's done concurrently. Retrospectively is too late. Best practice is concurrently, and I have done this as well. I have been involved with CDI programs that did it concurrently as well as retrospectively, and I have also been directly responsible for CDI that happened concurrently with coders, and I can tell you that that was best practice. They saw an increase of one of their case mix index by 1.5, which is phenomenal, almost unheard of. But what clinical documentation integrity is that it's going through the record, the documentation in the record, usually of the providers, physicians, PAs, nurse practitioners, while the patient's still in the hospital, how they've documented diagnoses and procedures, and clarifying those to make sure that they are clear, that they represent the clinical information that's documented in the record for the most specificity of coding at discharge or even during the hospital stay. So information systems that are used, you have obviously the EHR's documentation modules, you have coding queries, and then you have monitoring metrics. And so what are you looking at with the CDI program? Typically there's a dashboard and a threshold. Um, it says here physicians should agree with a coder and then gives you a percentage of the time. I understand that they like to have that for CDI programs, but you're dealing with individual clinicians, and they're not always going to agree. And the coder doesn't know everything. Whether the coder is a nurse or a coder, you're not always going to have that agreement. And sometimes if we stop and listen to our providers, we learn something as professionals and we understand why they aren't agreeing to amend their documentation or move it in that direction. And so I guess I would just, from a practical perspective, having lived this, I would just be very careful if you live and die by CDI thresholds. Just saying. All right, so that's it for chapter 16. Hope you're having a great week with your family and friends, celebrating Thanksgiving. I know everybody's telling you to stay away and all of that sort of thing, but hopefully you can touch base even if it's virtually. I look forward to talking to you next week about chapters 12 and 18, and I will see you then.